Right, so I don't know if you heard, we are going to record this session. And once again, I'd like to say to all of you, good morning, good afternoon, good evening. My name is Marty van Dieren. I am the program lead of the Healthy Mothers, Healthy Babies Consortium, which is hosted by the Micronutrient Forum. The consortium aims to drive collective action for improving maternal nutrition and specifically to accelerate the introduction of multiple micronutrient supplements in settings where diets are poor, where indicators on anemia or maternal undernutrition, low birth weight, etc. are high, and where we believe that multiple micronutrient supplementation can have a significant impact on maternal nutrition status. Today, I think, is the 5th or the 4th of our series of coffee and chai chats with experts around the world on various MMS-related topics. Before I introduce today's guest, I would like to quickly take you through the format of this session. It's short. Our guest will give an introduction of about 7-8 minutes on his topic. And during that time, I'm asking all of you to keep the audience mics muted. You can start putting in your questions in the chat box, of course. And also after the introduction, you can also raise your hands and we can give you the floor to ask a short question. During that session, if you're not speaking, we also ask you to keep your mics muted. Once you're called upon to speak, please introduce yourself, your name and affiliation. The total chat is only 30 minutes. We're recording it so that we can also put it online afterwards. But we would like to give everybody that is joining a chance to ask their questions directly to the expert who's on the floor. Now, I'm very pleased to welcome to today's coffee and chai chat, Mr. Mulamba Diese. Mulamba Diese is the program manager of Vitamin Angels in the Democratic Republic of the Congo. And I think you worked there since 2015 or 16 already. Mr. Mulamba previously worked at UNICEF, USAID, and the Center for Disease Control. He also has lectured on infectious disease and immunology, and he has lent his expertise to many other health and nutrition initiatives. Now, today, Mulamba will speak about the experience with multiple micronutrient supplementation in his country, the Democratic Republic of the Congo. Mulamba, I'm delighted to have you with us. Thank you for your time, and I'm looking forward to a stimulating discussion. The floor is yours. Gurmeet, could you please share the slides? And Mulamba, please put up your video and open your mic. Slides, please, Gurmeet. Thank you.
Thank you very much, Marty. Thank you, colleagues and everyone. And thank you for having me today to share our experience of MMS introduction in Democratic Republic of Congo. Can you help me put up my slide, please?
Without the music, thank you. Gurmeet, can you stop the music? Only the slides. Sorry about this.
I don't see as yet the presentation. Thank you very much. So I would like to share with you our experience on increasing access to multi-nutrient supplement, MMS, in the Democratic Republic of Congo. The Democratic Republic of Congo is in the central part of Africa. So I want first to, my presentation will be very short so that we can have time to discuss and for the colleagues to ask questions. Next slide, please. I'm part of the Vitamin Angel team, and the Vitamin Angel is a global, as all of us we know, a global health nutrition organization with the mission to help at high-risk population in need, specifically pregnant women, new mothers, and the children under 5, to have access to life-changing vitamin and mineral. Our strategy is set as follows. We know that most of those population reach at around 70%. And then we focus ourselves on 30%, which are not reached by a government effort. Using the following strategies, we advocate to create an enabling environment for MMS, and we provide technical assistance to ensure that there's an effective delivery of MMS services, and we provide resources. These include the MMS product themselves to increase the availability, but also some material, training material, and so on and so forth. In addition to that, we conduct implementation research to optimize implementation outcome as well as formative research. Next slide, please.
Next slide, please.
The Democratic Republic Congo is a very huge country with, it is estimated annually with 4 million pregnant women. And, but the country has a very bad health indicator. Amongst others, we know that most of pregnant women experience malnutrition status, mainly more in rural than urban areas. And the anemia is predominant in 40% of pregnant women, especially iron deficiency anemia. We also know, according to previous research, that 50% of pregnant women has a zinc deficiency and other macronutrient deficiencies. And we also know in the country that 164 per 1,000 live births have low birth weight infant. In terms of the ANC services, and most of the women attend the ANC, around 85%, but however, the service are very poor provided there. The country has already an IFA, and that is iron folic acid MMS policy back in 2011. It's been updated in 2017 to respond to the need of pregnant women and also the generalized malnutrition in the country. In 2018, VA's initiated MMS program. We start a stepwise approach from 1 or 2 provinces, as now we are covering most of the health district in the country. Next slide, please. Our approach is as follows. So we use a VA 2-pronged approach to increase access to MMS services. In one hand, we partner with the national government, and the other hand, we partner with VA program partner in distributing the MMS program services for under-served pregnant women. So what we need to do here, what we did for government, we launched officially the MMS program, and we conduct landscape analysis, and we provide the MMS to some zone de santé, which is a health district. And also we design and test implementation strategy to improve MMS uptake and adherence to for pregnant women. On the side of our VA program partner, for example, SANRU is a very big organization, local NGOs, which provide a lot of services. We donated MMS product to provide in many provinces under some projects. Some of them have been funded by a Swedish government at ANC platform. So we provide this product and also the training attached to that. That is, in general speaking, what we have done in the country.
Thank you
Next
very
one,
much.
please.
Yeah, maybe we can keep this slide up. Let's keep this slide up because the next slide is no text, right? Dr. Diese, can I ask you a couple of questions because I see questions coming in the chat box. And before I go to these, I actually would like to ask you, what is your reach in the DRC with MMS? Because you have those two approaches, but how many women are actually receiving MMS today?
Yeah, in the DRC, by the end of this year, we'll be reaching over 608,000 pregnant women with MMS services. That is across provinces, between around 15 provinces out of 26 that comprise the country.
And that is that a cumulative over the last years, or is that the number of women per year that you're now this year currently, that are now pregnant?
No, we started in 2018, and when we started small with 50,000, and each year we increased. For the last 2 years, we increased tremendously, and we went deep and wider geographically. So from 50,000 in 2018, now we are at over 600,000 to reach of pregnant women annually. Actually, that is
Good.
not
annually.
the sum.
That is,
annually. Last year it was 500,000.
That's very impressive. And I'll go to the chat box for questions. Pat McMahon is asking whether we know the severity of maternal nutrition in DRC. So what is, for instance, what is the average BMI, or how many women percentage have anemia? What are the figures on that?
More or less, according to the DHS, for 2014 is around 40% who has iron deficiency anemia, mainly anemia, but mainly iron deficiency anemia. Those are the figure which been tested in across the country. And also women, they have around 50% with some other micronutrient deficiencies. You name them: zinc, iodine, and others.
Excellent, yeah. And then there's a question by Naveen Paudial, I don't know if I pronounced the name okay, Paudial, asking whether actually in your partnership with the government, whether the introduction of MMS was built on an existing IFA supplementation program. So did the government counterpart agree to shift from IFA to MMS? And if yes, or what type of advocacy tool did you use to get to that decision?
Oh, yes. For MMS supplement at the ANC for pregnant women, DRC has actually leads the world in terms of public policy. As I said earlier, that they started to craft this policy and updated it in 2017. And now they didn't have any product to provide to pregnant women. So they could provide only the IFA, because that it was available in the country. And again, it was not provided for free. Women must go and buy. Now, when VA initiated the program, we were welcome. So the door was already open in terms of policy and enabling environment in the country. So with series of meetings, and people were very happy to see that. And so we start to provide the service across the board. We started first at a small level, according to our mean, as we are expanding over the years. But there are obviously our policy, because we provide this service at the ANC platform, and our VA partner and others, community organization, provide support door to door, and also what we call site of care. Site of care is in a rural area where there's some of our VA and community health organization which provided services in the villages for pregnant women. So those are the sites where we distribute our MMS.
Right. And now there's a couple of more questions, and I'm not taking them in the order because I'd like to build on that, the implementation that you're talking about now. So there's a question from Luin Mar Liang, who's asking about what type of monitoring do you do on MMS distribution? What type of monitoring mechanism exists?
Because for us, MMS product is a standard of care now in Democratic Republic of Congo. We do have a monitoring at 2 or 3 levels. The first one is the service delivery as one bars at the ANC for pregnant women. So people are going there, checking about adherence and asking questions if the woman receive, if she's taking tablet, because our formulation for VA is the bottle of 180 tablets. So women must take 1 tablet a day. So for every each visit at a facility, and the service provider is checking if the woman has been taking that. That's one thing. Second thing is on a regular basis, according to the government guideline, for women who comes, they check some others parameter, including hemoglobin, and they look at that. But there's additional monitoring for services is our VA partners. So the VA partner goes door to door. So they are grouping in a women club and a community health organization, such a way they go they meet with the woman to make sure that she's taking the tablet, if she has a question about the tablet or not. Those are the way we monitor that the woman is taking the tablet. Now, at the program level, we need to make sure that each woman is being offered the MMS product, unless if she decline not taking them for some reason or religious, whatever could be the case, then in those cases will be discussed with the head of service delivery at a health facility. But otherwise, we make sure that the service being provided to her, and she got the product and she's taking it. Now, on a report on monthly basis, all those sites report to the health facilities and to the district health facility, where we have, as a VA, got those data, and to make sure that we do on monthly basis, we can say how many women they put and offered MMS program in DRC.
Thank you very much. And I just want to have your confirmation that let's say the compliance, the question of how many is she taking, that's reported by the woman, or is it really the count of the number of tablets that she still has left?
Yes. In fact, as some of the colleagues might know, in African context, when the woman goes to ANC, most of the time she's not alone. So she comes with either her own mother or aunt or the mother-in-law to support her, or sometimes with the husband, really sometimes. So when she reports the tablet she's been taking, and if she forgot something, and she might be called to either mother or brother who supported her to say, okay, did I forgot something? And what we've also noticed that from the beginning of pregnancy, the first trimester and so on, because the women always come with the morning sicknesses, and the way they've noticed, reported that really anecdotally, that when they start to take MMS, they feel better, and even the vomiting is decreasing. So that is the report from the women themselves.
Right. Okay. Thank you very much. Now, basically, there's another question. There's a lot of questions, so I'm going through them. How well is MMS accepted by both the health worker and by the women in terms of acceptability for taking, for the side effects that, you know, IFA we know about?
Yeah, let's start to talk about the most important person is the woman herself. Yes, in DRC, Martin, some colleague may know, is out-of-pocket health services system. So what's happened is with MMS, it's been given for free, and that is a big bonus for the family, which are living with less than $1 a day. So that is one. Two, especially when she takes, I mentioned that earlier, that when she starts to take, she feels much better and she feels strong. And you know, the burden of work at family level is always on the woman, even if she is expecting. So, and that is actually they report themselves that I'm feeling better. And that is the way she, by word of word, she speaks to other colleagues of hers. So, you know, you must go there and I'll receive this. Maybe if you start early, you end the services, a consultation, they will give you this.
And that is actually, oh, excuse me, go ahead.
For the service provider, that is a bonus, especially for private sector, because our VA program, we don't give only to the state institution, but we give also to the private sector. Those mainly could be not for profit or faith-based or some community-based. So introducing MMS improve actually the attendance of ANC, because women will say, oh, if you go there, you will receive this for free.
Mm-hmm. And I am sorry that I interrupted you almost, but that is because one of the questions is what is your communication message when you give MMS, right? Because when we promote IFA, iron folic acid, the general message is it corrects iron deficiency anemia. Now here the women, they like taking MMS because it makes them strong, but is that the message you give, or is there an other specific message that you give?
Yes. Besides that, we speak about the woman becoming strong, and she wants worried about anemia. So when we talked about the newborn, and that is very critical for a pregnant woman. She would like to know how will be a child. Talking about MMS, we always put across the fact that the MMS provide reduced the rate of low weight weight amongst, which is very high rate and prevalence in the country. And so when we put that communication across, and people will really like, especially when there's somebody around women, she actually stimulate the woman to take the tablet on a regular basis, because she would like to see a child born healthy than if it's very weak and very small. And that is one of them. And the two also, it's to make sure that she won't spend more time in taking the child for any other diseases, because they provide the protection until the child will reach 6 months to get now vitamin A supplement and so on and so forth. So that is a main communication which we provide to the woman. It's actually stimulating.
Thank you very much. And there was a question that was actually asked very much in the beginning already. Has there been an evaluation in the DRC on the impact of MMS on low birth weight? Has there been a study in the country?
No. VA has initiated currently, and we completed our landscape analysis for MMS, but we know that by next year, we will undertake additional studies. But for that one, we haven't done that in DRC as yet. We know that some of the universities are very, very keen because now everybody knows that we have MMS. We've been communicating with them. They've been reaching out to me to say that they would like to look at some of the aspect is low birth health, how it improved because the rate is quite high in DRC given the state of malnutrition across the board for amongst pregnant. And our policy as a VA is just if somebody would like to do that, we are welcome, but we would like to be involved at the protocol level to make sure that everything is done correctly. That I will share with my leadership United States so they can look at that and advise me on the guidance in a way the protocol can be improved. So until they will submit that, the discussion is still holds the intention. People would like to do that.
Mm-hmm. Well, there are, of course, quite a number of studies done over the last 20 years. So, and there are a number of, there's 2 meta-analyses that have been published, and there is one question that's actually asking about the results of those, saying what is the additional benefit promoted for MMS over the maternal IFA supplementation? Can I ask you, Dr. Diese, to, if you know the numbers by heart, to answer this question? So what is the additional benefit of MMS over IFA in reduction of low birth weight, reduction of stillbirth, or small for gestational age, for instance? If you have the numbers ready.
Yes, I don't have the number by heart, but I know in addition to that, just looking at the composition of MMS in DRC, at least in a particular way, we know that besides the low birth reduction, besides also the prevention of some of the infection for the newborn, but the most important here is prematurity. And when you have a child with the premature in the DRC, the chance of child to survive is very little. So if we improve that, and that is actually a big bonus, and that it has been actually observed. That's why I didn't want to talk about the study per se. It's been observed where we are working for the last 3.5 years now, and where the service provider, the doctor is telling me that they've noticed that they don't see as usual the high prevalence of prematurity with the newborn. And that is a really a big bonus because with a prematurity is a high mortality, is a high infection rate as well. Yeah. So, and that is one of the big bonus for MMS. Obviously, there's others also.
Yeah, and actually to answer the question, there is in the chat box now a link to the meta-analysis. And for the person that asked the question, I can tell you that from the meta-analysis, we know that there is a 12% reduction in low birth weight if we use MMS instead of IFA. So the differential effect of MMS on IFA for low birth weight reduction is 12%. And there's another question, and I think we're getting to the final question. Are there any known side effects of consuming MMS?
We haven't gotten a report, from any service provider or institution telling us about the side effects. So we can't really tell now that there's a such. Anecdotally, and we heard that maybe the change of the color of the stools, maybe some of the see that the stools coming a little bit darker, but that is come with iron, and you can see it because iron is in MMS and also in IFA. So we haven't record any really side effect. Although we talk about people looking at that and so that they can let us know, we haven't gotten.
Yeah. And actually, this was the last question. And I really want to thank you because we have been talking for half an hour, as we promised people. We shouldn't go over time. If there's more questions, just let them know to the Healthy Mothers, Healthy Babies Consortium. We will pass them on. We'll try to answer them. I think I really want to thank you, Dr. Diese, because I thought it was very interesting. We had a lot of participants, a lot of questions, and you can see that this is really, people are interested in the experience in the field at country level, you know. What I would like to say at this moment, there was also a question about the Healthy Mothers, Healthy Babies Consortium, whether we're doing also, we're also looking into other interventions for maternal nutrition apart from MMS. And I think that's an excellent question. We know that this is important, and we do want to also encourage all types of interventions for maternal nutrition and improving that. I must admit that at this moment, we do not have a particular focus on what you asked, the balanced energy protein supplementations, but we may in the future really pay attention to that as well. Now, to close off and to thank everybody that has been with us, we had, I think, about 30 participants. So this is the highest number so far for these expert chats. I would like to thank all of you for this interesting discussion, for your questions. If you want to know more, please look at our website, visit the Knowledge Hub, or write us. And we have a next chat on the 4th of November with Dr. Megan Bourassa, who is leading the MMS Technical Advisory Group, and she's based at the New York Academy of Sciences. And Megan will talk about the evidence on adherence to micronutrient supplementation. So this will not only talk about MMS, but will pull together the evidence that exists also on other micronutrient supplements. And I'm very much looking forward to all of you joining us again on the 4th of November. Thank you, Dr. Diese. Thank you, everybody. And let us know any of your other questions. We are compiling, by the way, a FAQ from all the questions that we're receiving throughout these very short expert chats that then we also will like to make available through our various channels. Thank you very much and have a great day. Bye-bye.